I'm Mark Fendrick, Professor of Medicine and Public Health at the University of Michigan, where I direct the Center for Value-Based Insurance Design. I'm active in the practice of general internal medicine and have spent most of my career trying to figure out how we could spend our healthcare dollars better. From a physician's perspective, I think all of us know that over the past several decades, we've produced remarkable medical innovations resulting in impressive improvements in individual and population health. Regardless of these clinical advances, it seems to me that cost growth, or how much we're spending, remains the principal focus of healthcare reform discussions. And despite the evidence of clinical benefit, Americans systematically underuse high-value services across the entire spectrum of care. Immunizations, doctor visits, drugs, cancer screenings. It seems like all of them are underutilized. So because there's enough money in the system, I think attention should turn from how much we spend to how well we spend our healthcare dollars. What is one of the problems that's keeping us from doing this? Well, what we have focused on is what we call one-size-fits-all cost sharing. Whether you're in a public plan or a private health plan, it seems that individual or consumer cost sharing for medical services and providers are the same for high and low value services. You pay the same out of pocket for every doctor visit, every diagnostic test, and every drug, whether it be a life-saving drug for diabetes and cancer, or a drug that makes your toenail fungus go away or your hair grow back. So this one-size-fits-all cost sharing, we believe, is in fact leading to inefficiencies in healthcare spending. There are those now that believe that if you make Americans pay more, they'll spend their money wisely on healthcare services. Skin in the game. Well, as we look at the evidence, as we make Americans pay more for healthcare services across the board, they stop buying the bad stuff, which is why you have cost sharing, but they also stop buying those services that I beg my patients to do. The evidence is overwhelming for drugs, for cancer screenings, in this case mammography in Medicare. If you make people pay more for something, they will buy less of it, regardless of its clinical evidence and impact. Our approach to the one-size-fits-all problem is clinical nuance. Clinical nuance has two basic tenets. The first is medical services differ in the clinical benefit provided. Some doctor visits are more valuable than others, some diagnostic tests more valuable, and certainly some drugs produce more clinical benefit than others. The second is that clinical benefits of a specific service depend on who receives it, who provides it, and where. You can imagine, if you look at the example of colorectal cancer screening, how old you are, what physician provides that service to you, and whether, say, you get it in an ambulatory care center or a hospital might matter in terms of the value that that clinical service may provide. So we put together clinical nuance and cost sharing together into clinically nuanced cost sharing. We set a health plan for which high-value services patients face low or no clinical barriers. For those services for which the evidence is weak, or in sometimes where evidence there's harm, individuals will pay more than they pay for the services that make them healthier. This is implemented as a concept called value-based insurance design. Value-based insurance design bases consumer cost sharing levels on the clinical benefit, not the price of the service provided. We reduce or eliminate financial barriers to high-value, evidence-based clinical services. We've been talking about value-based insurance design for over a decade, and it's been successfully implemented by hundreds of public and private payers. What is the evidence? Do these health plans work? Well, in July of 2013, Health Affairs published a systematic review of 13 VBID studies. The VBID programs consistently associated with improved adherence with high-value services. It lowered consumer out-of-pocket costs, and there was no significant increase in total spending by payers. Since most of these incentive-only or carrot VBID programs do not produce large amounts of aggregate cost savings, it's important for us to understand what are the features of VBID programs that actually produce the greatest results. A 2014 Health Affairs study looking at 76 VBID plans reported that VBID implementations that were more generous, targeted high-risk individuals, offered wellness programs, avoided disease management, and used mail-order formularies had a greater impact on adherence than those plans without these features. So we've had great progress in the commercial sector. It's also important to point out briefly our success in the public policy realm as well. VBID is implemented in the Affordable Care Act, also known as Obamacare, in Section 2713. This section removes patient cost sharing for selected high-value preventive services. These include those rated A or B by the United States Preventive Services Task Force, immunizations recommended by the CDC, and preventive care and screenings for infants, children, and women. At this stage, over 100 million Americans have received expanded coverage for some preventive services. VBID has also been implemented on the statewide level. CMS approved a rule in 2013 enabling VBID in Medicaid. VBID has also been implemented in state employee programs across the country. And also there is renewed interest in VBID in Medicare. VBID was included in the Better Care Lower Cost Act of 2014, and notably, a call for a VBID demonstration in Medicare Advantage was noted in the 2015 Medicare Advantage call letter. What I find most fascinating is the broad multi-stakeholder support for value-based insurance design. From labor organizations to manufacturers to bipartisan political support, this intuitive idea seems to be taking hold. As we think about applying VBID moving forward, it's important for you to consider the fact that many supply-side or provider-facing initiatives are restructuring provider incentives, payment reform, tiered networks, and health information technology. I call these provider-facing initiatives peanut butter. As we think about VBID, shared decision-making and literacy, these supply-side initiatives have historically paid very little attention to consumer decision-making or demand-side initiatives, which I call jelly. And no matter where you sit as a healthcare stakeholder, I want you to remember the magic, the first time you put peanut butter and jelly together. Because the alignment of supply and demand-side incentives can improve quality and achieve savings much more efficiently than either one of these implementations alone. The ultimate test of healthcare reform will be whether it improves health and addresses rising costs. Public and private payers are increasingly moving toward clinically nuanced, value-based insurance designs to produce more health for the money spent. To learn more about value-based insurance design, please visit the University of Michigan Center for Value-Based Insurance Design website, follow us on Twitter, or reach us through the email address here. Thank you very much.